Alright, so AP pelvis bilateral hips. Patient is supine. You're going to rotate those limbs internally for non-trauma 15 to 20 degrees. You can see that they're rotated in. Most patients can hold them in. You're not going to have to tape them, but special cases you may have to. Central ray is midway between the level of the ASIS and the symphysis pubis. So ASIS, symphysis pubis, so halfway in between that ASIS and symphysis pubis is where you're going to be. So approximately 2 inches inferior to the ASIS or 2 inches superior to the pubic symphysis. And you can locate that ASIS easier, so ASIS 2 inches inferior to that. Top of the image receptor is just superior to the iliac crest, approximately 1 inch to 1.5 inches. So you're going to find your iliac crest and make sure that that cassette is about 1 inch, 1.5 inches above that iliac crest for that pelvis. You're going to be down the midline of the patient and then midway between ASIS, pubic symphysis, legs rotated in 15 to 20 degrees. So your pelvis criteria, you want the entire pelvis and proximal femurs. So proximal femurs here, you can see that lesser trochanter is hidden. The greater trochanter is in profile, nicely viewed. You see both of the iliac crests and a little bit above them, about 1.5 inches, 2 inches above that iliac crest. Both wings of the ala are visualized. No rotation of the pelvis. The ala is equal on both sides. Lesser trochanter not visible. Optimal exposure factors. So AP bilateral frog leg projection, pelvis and hips. This is modified Cleaves method. So make sure you know the method name, modified Cleaves. This is if you're doing both frog legs, okay? So you're going to abduct the femurs 40 to 45 from vertical, okay? So central ray is perpendicular, 3 inches below the level of the ASIS. So you are farther down the ASIS than midway between the pelvis, the symphysis pubis, and the ASIS. So just a little bit farther down from that ASIS, another inch. And then you're going to do 20 to 30 degree abduction, is less foreshortening of the femoral neck, but more of the entire femur. So what they're talking about is you are... normal is 40 to 45 from vertical. If you want to visualize the femoral neck with less foreshortening, then you're going to go 20 to 30 degrees abduction. So just kind of make sure what the image is calling for, why you're doing the image, but there are a couple of different ways to do it. Either that 40 and 45 or that 20 and 30, but also keep in mind you're going to do what your patient can do as well. So AP bilateral frog leg projection, pelvic girdle is centered horizontally. You've got no rotation. You are clipping the iliac crest, but we're more interested in the femurs and the distal part of the pelvis. So lesser trochanters are equal size, which you can see here, the lesser trochanters. Greater trochanters are superimposed over the femoral neck right here. Okay. And then you have optimal exposure factors. You've got the gonadal shield. So this is optimal. So keep in mind, like I said, you may not shield. More than likely, you're not going to shield for frog legs. And then also more than likely, on adult patients, you're not going to do bilaterals on one image. You're going to do individuals. You're going to do a right frog leg and then a left frog leg. And when you do a right and left frog leg, your image more than likely will look like this, okay? So this is what you're going to image on that frog leg, picking up that pubic symphysis, and then your other one is going to be the same, and it's going to come down, and it would come down right in here just to pick up that pubic symphysis. Okay, so keep in mind it's probably going to be two images, a right and a left, but include that pubic symphysis in your right and in your left frog leg. So hip, non-trauma hip, basic series. is an AP. AP of the proximal hip, frog leg lateral. Some facilities may include an AP pelvis as part of the series. So your non-trauma hip, it may be a hip, but you're going to do an entire pelvis and then frog leg. So say you have a right hip, your protocol is going to be the entire pelvis and then frog leg of the right hip. That's what you're going to send off to the radiologist. If bilaterals are ordered, some facilities may do an AP pelvis, so you're going to do your AP pelvis. Frog leg lateral will more than likely be unilateral, so you're going to do a right frog leg and a left frog leg. You're not going to do both of them on one image. So now we move to the trauma hip, which is an AP pelvis, is almost always included in a trauma. That's where they start to begin with. Trauma pelvis, so you're going to do the pelvis, no rotation of the legs, and then you're going to do a hip, and then non-rotational lateral hip, cross table lateral. So the affected hip after the AP, then you're going to do a cross table hip. A lot of times your trauma hips are an AP pelvis. They skip the AP hip and they go right to the cross table lateral hip. So AP pelvis and then the cross table lateral, just depending on where you are and what your protocols are. So keep in mind, you may not have to do an AP hip. So hip and proximal femur, AP unilateral hip. So this is individual hip, central ray perpendicular to the midfemoral neck. If there's an orthopedic appliance, central ray may be distal to the femoral neck, 1 to 2 to 3 inches, just depending on where you think that prosthesis is going to end. But you can also do proximal and distal femur. That way you have both on there and you get the entire orthopedic appliance. Make sure you rotate that leg 15 to 20 degrees in if it is a non-trauma. So criteria for your AP unilateral hip and proximal femur. So you're going to include that pubic symphysis. So this is really good. So you've got ASIS, pubic symphysis, proximal femur. Your lesser trochanter is hidden. Your greater trochanter is in really nice profile there. So proximal third of the femur included. Hip joint space and acetabulum are visualized. So your acetabulum, hip and joint space are visualized. Lesser trochanter, like we said, is not visible. Greater trochanter is visible. Optimal exposure factors. Head of femur is seen through the acetabulum, so you can see that nice head of the femur. This is the acetabulum here. The greater trochanter profile. Most of ilium, ASIS, and all of pubis, to include the symphysis, is visible. So that's a really good AP hip. So if you have a prosthesis, so include all or any of the orthopedic appliance. So if your image had clipped here, what you're going to do is just move your central ray down so you find the end of that prosthesis. You need to include all of it, even if it requires an extra image. So your unilateral frog leg projection, modified Cleaves method. So once again, the unilateral frog leg, modified Cleaves, is a non-trauma only. Don't attempt post-op. So if they've been operated on, don't do this. You're going to do that cross table hip. So you're going to abduct the femur 45 degrees from vertical. So you bend the knee and then lay that knee over as much as the patient can. The Lowenstein method for best demonstration of the femoral head and acetabulum, you abduct the femur 90 degrees from vertical, 20 to 30 degrees for less distortion of the femoral neck, and then your central ray is perpendicular to the mid-femoral neck. So sometimes you can do it on, you can turn the tube head this way. Just make sure that you're going to get it on that image receptor, or you can leave it this way, on, say, like an 8x10, and you're going to pick up that proximal femur, the acetabulum, the femoral head, and then you're also going to include the pubic symphysis in there. So either one of these is not wrong, turning the tube head or leaving it crosswise and matching it up. Just kind of follow your text and then see what they do and then what the protocol is for your clinic site. So criteria: unilateral frog leg, you want to see the entire femoral head, which you do, the neck, the greater trochanter overlying the neck, the lesser trochanter and profile. You're picking up that pubic symphysis, you're not clipping it, and then you're right at that ASIS. And this is a 45-degree abduction, so 45 can be anywhere from 20 to 30 degrees, 45 or 90 if at all possible, just depending on what your patient can handle. And keep in mind it's non-trauma, so there is no trauma to that. You're just doing a frog leg. So unilateral hip frog leg projections. This one is 45 degrees, the modified Cleaves for the femoral neck, and you can see that femoral neck. This is 90 degrees, which is the Lowenstein method for the femoral head and acetabulum, which you can see the head a lot better and see that acetabulum right there. And this is 90 degrees out. The only thing that's missing here is they're missing the pubic symphysis, so make sure that you pick that up in your images and you'll be good to go. So your axiolateral inferior superior, also known as the Danelius-Miller method, the unaffected leg is going to be raised up. Sometimes you can prop it on that tube head. Other times somebody's going to have to hold it up. However you have to do it to keep it out of the way. And your central ray is coming in, and you can see that it's coming in to that femoral neck and then to that image receptor. So that image receptor is placed at the angle of that femoral neck. So it runs parallel with the femoral neck and the image receptor. And then your central ray is a cross table into the femoral neck and into your image receptor. So central ray is perpendicular to the mid-femoral neck. So trauma lateral hips, the following are trauma lateral hip projections that we'll run through. So axiolateral hip, the bedside mobile procedure. So this is if they're in a stretcher. If they are able to help, they can hold this cassette. You can see that they're built up a little bit on that hip. You're just going to have to be really careful. A lot of times techs will work in teams, or if they're working by themselves, they'll take this and they'll push this down into the bed. So it actually goes below the leg and the soft tissue to better image that cross-table hip onto that image receptor. So usually a 10x12 image receptor, but with digital, we're just going to use whatever cassette comes with the digital, usually 17x17, 14x17. Are what those digital receptors are. Holding it crosswise, it'll be lengthwise to the long axis of the femur. Okay, so you're trying to put it long axis, and the long axis that we're looking at is the long axis of that femoral neck. So it cassette here and then the femoral neck this way, so you want to run it parallel with that femoral neck. So the central ray is perpendicular to the femoral neck, image receptor parallel to femoral neck, collimate, evaluate the unaffected leg. Can they hold it up there? Do they need some help? And then usually you are 80 to 85 kV with a grid, and then you're collimating small to avoid scatter and imaging that femoral neck and head. So this is a really good modified axiolateral hip, the cross table, the Danelius-Miller, sorry, right here it is. So this is the Danelius-Miller, the axiolateral hip bedside. So you can see the head of the femur that's been replaced. You have the entire prosthetic device. Here you've got the acetabulum, the femoral head, the femoral neck, greater trochanter, lesser trochanter, greater trochanter, lesser trochanter. So the entire femoral head, neck, and acetabulum should be visualized. And then optimal exposure factors. So we're going to move on to the modified axiolateral, the Clements-Nakayama method. So make sure that you know this one, Clements-Nakayama. Make sure you know how to spell it. So this one is your central ray is 30 to 40 degrees medial lateral and then 15 to 20 degrees posteriorly from horizontal. So you can see that there's an angle here, but there's also an angle down. Okay, so CR is perpendicular to the femoral neck. Can't use a grid because of this double angle, this angle and this angle. You're not going to be able to use a grid. So this is leaned back here to compensate for this angle here. Okay, and then this here is this angle that's on the tube head this way. Okay, so you're entering still at that femoral neck, and they're showing you right here pubic symphysis, the femoral head, the femoral neck, and then that's where you're visualizing it in and then to that image receptor. So central ray is centered to the femoral neck. You're not going to lift either leg. That's why you're using those double angles. And you're going to visualize it like this. You're not picking up that pubic symphysis, but this is a really good Clements-Nakayama. You're seeing your acetabulum, the head, the neck, the greater trochanter, the lesser trochanter, femoral head in profile, and as well as the neck in profile. And you're doing this because the Clements-Nakayama is used if there is suspected fracture in both legs where you're not wanting to move either leg. So you're going to get this image and then you're going to move over and get the opposite image of the other leg as well. So keep that in mind. The only time you do a Clements-Nakayama is if you are suspecting a fracture in both femurs. Okay? So special projections of pelvis and acetabulum. Let's see, I think I'm going to cover this, okay? So, axial outlet projection, Taylor method. So, Taylor method, make sure you listen to those ASRT videos because they go through these inlet outlets really, really well. So, your central ray for your outlet is a cephalad angle on a 10 by 12. Your central ray is 20 to 35 degrees cephalad for males. Make sure that you know these differences. 20 to 35 for males. 30 to 45 for females. Your CR is centered 1 to 2 inches, which is 3 to 5 centimeters distal to the symphysis pubis. So symphysis pubis by the white line, and then you are 1 to 2 inches distal to that, with the angle appropriately for male or female. 20 to 35 for males, 30 to 45 for females. So this is your outlet view, the axial outlet. You're going to see these obturator foramen enlarged, so elongated and magnified pubic and ischial bones. So your pubic and ischial bones are elongated, your ischial tuberosity, your inferior ramus, your superior ramus, the bony pubis, those are elongated. Everything is centered. You see your symphysis pubis is elongated, and you're seeing that outlet really well on the pelvis. So your inlet, your CR is 40 degrees caudad. So this is for everybody. So the inlet, 40 degrees caudad. And you can see your symphysis pubis is here. So our central ray is going to come to the ASIS. Okay, so central ray at ASIS and 40 degrees caudad. So criteria of the apiaxial inlet. So inlet, and then the outlet is down below. So the inlet, you're going to see the elongation of the sacrum and the coccyx. You're going to see your ischial spines really well. the inlet superior aperture here, the upper body of the ischium here, the left ala, the right ala, those are all elongated. It's an axial projection that demonstrates the pelvic ring or inlet, the superior aperture in its entirety, and they're talking about this right here. Okay, so this ring in its entirety. Okay, and it's the only image, the inlet, where you see that entire ring. You won't see it on the outlet. So Judet method, Judet, posterior obliques, so of the acetabulum. So central ray is 2 inches distal and medial to downside of ASIS. So ASIS, find your ASIS and your 2 inches distal and then medial to that downside. So the other one is CR 2 inches distal to the upside ASIS. Okay? So this is when you're visualizing the upside. This is when you're visualizing the downside. Okay? So RPO is the downside, RPO downside, LPO upside. So anterior rim and posterior ilioischial column are demonstrated, and then the LPO, the posterior rim and anterior ilioischial column, is demonstrated. And you may have to do this. So there are facilities that do a 14 by 17, okay? And you're going to central ray to the center. So what you're doing is you're doing 2 images where you're seeing this upside and this downside. And then you would move the patient, do a 14 by 17. So now you're seeing this downside and this upside. So they're doing basically bilaterals together, but it just depends on the method, depends on where you're at, depends on if it calls for right or left. If it is an individual, you're going to do downside and upside. If it's calling for bilateral, you're going to do them both together. So patient rolled RPO, image both of them. Patient rolled LPO, image both of them. So just keep that in mind. And this is what your images should look like unless you're doing a bilateral, and then one's going to be down, one's going to be up. Just make sure that you know what you're doing for your protocol. Okay, I'm going to end here, and then we've got some images to critique and a little bit of quiz me on the next video. So that'll finish up the positioning for the pelvis and femur. So let me post this one and I'll get back to you with the next one.